Johnson. I'm happy to give my screen up if it's an appropriate time for that. There we go. So Dr. Johnson, if you don't mind, I'll talk a few words about you. So Dr. Johnson hails from the Mountain West in Utah, but gave the East Coast a fair shake when he attended medical school at the University of Pennsylvania. He then made a wise trip back west where he came to Stanford, where he completed medical residency, a chief resident year, and then his hematology oncology fellowship. He subsequently joined Stanford's faculty 5 years ago and currently has an appointment as a clinical assistant professor of medicine. Dr. Johnson has a clinical focus and expertise in gastrointestinal malignancies. His most recent clinical trials involve neuroendocrine, colon, liver, and pancreatic tumors, one of which looked at the activity of atezolizumab, which we'll hear about in his talk today. He serves as the assistant director of the inpatient service at Stanford, and he clearly has a passion for teaching over the last 15 years at all the places he's been. He expressed enthusiasm about the opportunity to teach us tonight, similar to his enthusiasm for other teaching that he's done, and we look forward to hearing from you, Tyler, on systemic therapy for HCC.
Great. Thank you for that very kind introduction, Dr. Holt, and thank you to all of you for the invitation and the chance to speak to you tonight. Let me share my screen. Let's see. Does that work? Let me make sure this is okay. Can everyone see my slides now?
Perfect.
It looks great.
And you can hear me? Can I just get a thumbs up? You can hear me? Okay, perfect. All right, so I'm here tonight to talk about systemic therapy for hepatocellular carcinoma. And of course, we always want these presentations to have an interesting title, so I'm calling this a new era. That may sound a little bit dramatic, but those of you who are familiar with the progress in the systemic therapy for HCC over the last 5 years will know that it really, in this case, is not. I also want to mention that I appreciate Greg Keystand, who loaned me a number of the slides that I've used in this presentation. He's a colleague of mine here at Stanford. I have no relevant disclosures to make. So the thing that I think is the most important to appreciate about the systemic therapy for hepatocellular carcinoma over the last 5 years is that we have undergone a genuine paradigm shift. I'll talk about the details underlying this paradigm shift throughout my presentation, but the most important thing that you need to know is really summarized on this slide. So those of you who have been taking care of hepatology patients for many years will know that HCC is distinctive, if not unique, among solid tumors in the sense that for many years, the medical oncologist literally had nothing to offer the patient with hepatocellular carcinoma. So even into the early noughts, we just really didn't have anything. And all of the systemic therapy options that we have, that we use for all of the other solid tumor malignancies that we see in the GI tract from the esophagus all the way down to the anus, which are almost universally effective in other solid tumor malignancies, really have little, if any, effect in hepatocellular carcinoma, and it stood alone in that very bad way for many, many years. Finally, in 2007, we had the approval of sorafenib, and I'll talk a little bit about the use of sorafenib tonight. Most of you are probably familiar with this medication because it's been in circulation for this disease for many years. But what's remarkable is that it stood alone as really the only systemic treatment for hepatocellular carcinoma for more than a decade. And then all of a sudden, in 2019, you had this cascade of other treatments that have now become available that have greatly changed the way that we approach our treatment of this malignancy. I think before we get into the weeds talking about the specific therapies that we can offer to these patients, I think it's important to take sort of a 30,000-foot view and just describe. So as Dr. Holt mentioned, I've been in practice for about 5 years. And when I started as a medical oncologist, when we had patients who were referred to us for hepatocellular carcinoma, frankly, I almost felt bad that they had been referred to see a medical oncologist, because basically what I would do is I would look at their case and look desperately for anything else that we could do to help them other than systemic therapy, because at that point, the only thing that was available to us was sorafenib. And we'll talk about the effectiveness of sorafenib in a moment, but the short version is it's really not all that effective, and almost nobody likes taking it. And so what we were left with was this situation where I would basically beg and plead with the interventional radiologists to figure out some other liver-directed therapy to offer to the patients so that we could forego sorafenib as long as possible, unless they had convincing extrahepatic disease or truly got to the point where we just had no other liver-directed therapies to offer them. Now, however, that situation is much more complicated. And now when we have patients who are referred to us for systemic therapy, we end up having a very nuanced discussion, and there's much more give and take between us and the surgeons and the interventional radiologists trying to talk about how we can best balance the benefit that they may get from the systemic therapy options that we have versus the benefits that they may get from having liver-directed or other localized therapies. And we'll talk a little bit about the menu of options that we have. Dr. Holt, I just want to make sure that I clarify, what time would you like me to transition to questions and answers?
I think that if you ended between 6:35 and 6:40, that we would have at least 5 minutes for questions.
Okay, perfect. Thanks. So one thing that I want to mention that is going to be almost universally applicable as we talk about all of these things, although I will talk about some exceptions to some degree to this rule, but I think it's important to note that the one, you could call it the Achilles heel of the treatments that we have available, is that almost all of them are dependent on liver function to some degree, or at least they are, most of them have only been trialed in patients who have pretty good residual liver function. This obviously creates a paradox because most of the patients who are referred to us for HCC have pre-existing liver conditions. Many of them have already developed cirrhosis. And so that does create, there is still a pretty big hole here where we have a number of patients, often the sickest patients, who are referred, they already have cirrhosis, especially if they're child Q, B, or C. They can be in a position where even though they desperately need systemic therapy, we may not have a lot to offer them. And I'll talk a little bit more about the details of that, but I think it's important to acknowledge up front. So this is just sort of a schematic that talks to us about some of the things. This does not cover all of the things that are available, and in particular, this doesn't cover immunotherapy, which we'll get to a little bit later. But I think what it does do is it talks a little bit about many of the options that are available for our HCC patients, with the exception of immunotherapy. What you'll see here is that if you look at, so I've listed FOLFOX as an option here. FOLFOX is an old-fashioned non-specific cytotoxic chemotherapy that we use much more commonly in things like colon cancer and gastric cancer. We talk about using it in hepatocellular carcinoma, but the truth, as I mentioned earlier, is that it really is not particularly effective. Most of the things that we use either fall under the heading of immunotherapy or targeted therapies. You can see here that we have this whole list now: sorafenib, lenvatinib, regorafenib, cabozantinib. All of these, even if you're not super familiar with the details of chemotherapy, you can probably tell that these are all small molecule inhibitors. And they all have a relatively dirty mechanism of action, which is to say that we want them to attack one certain receptor, but they often attack many other ones, which gives them a lot of off-target effects. They also tend to have a pretty similar efficacy profile, which I'll talk about in a little bit more detail. Some of them are technically improved for first-line use, others for second-line use, as is listed here, and we'll talk a little bit more about how that works over time. So I think it is still important to reference sorafenib. So sorafenib, as you know, is a small molecule inhibitor. This is by far the therapy that has been available for the longest. It's an interesting drug for a number of different reasons. One is that it was, so to be clear, it is an FDA-approved therapy, and it was demonstrated in a relatively large randomized controlled trial to lead to a statistically significant benefit in median overall survival. So as much as I was sort of joking about doing everything that I could previously to avoid using this drug, and even though that is really true to some degree, it's important to recognize that it was the first FDA-approved systemic therapy for HCC, and it certainly remains something that we use at times. You can see here that the improvement in median overall survival was on the order of a little bit less than 3 months, maybe 2.5 months, which was statistically significant. But again, that's certainly not a game-changing therapy in the way that we would really like to see. The other thing is that this is really, even on the spectrum of chemotherapy, where none of the medicines that we give are patients' favorite things to take, this is a pretty yucky drug. And I would sort of describe the kinds of side effects that this can have as falling into two buckets. So on the one hand, there's a list that's as long as your arm of very dangerous acute side effects, including bleeding and blood clots and other sometimes life-threatening things that can happen on this drug, which, while any of them individually is relatively unlikely, when you add them all together, it's a not insignificant chance that you can develop one of these toxicities. Even apart from that, though, because we have more patients who do not develop one of the overwhelming acute toxicities than the ones that do, but even the patients who don't develop that, it's just important to know that most of them really don't feel very good on this drug in a way that is maybe more difficult to quantify, but is no less real. So it's very common when we have patients on this drug who they come back after their first month or so on it, they describe feeling really tired, under the weather, sometimes even depressed, say that they, just don't feel, they feel sort of like life has lost its shine a little bit. And I think that's important to remember when we're talking about putting people on this drug. Now, these are some other small molecule inhibitors. We'll come back to lenvatinib, which is the other one that's approved in the first line setting in a moment. This is regorafenib and cabozantinib. These are medications that also have applications in other GI malignancies. Specifically, regorafenib has been approved for use in colon cancer. But what I hope you'll notice when you look at the efficacy profiles of these drugs is that they are relatively similar to the numbers that you saw with sorafenib, right? So here with sorafenib, you see a median overall survival benefit on the order of 2.5 months. And then if you look at regorafenib and cabozantinib, it's almost exactly the same, right? So the median overall survival benefit is on the order of 2.5 months, pretty much with all of these drugs. Now, I will mention that in the case of regorafenib and cabozantinib, because these are approved in the second line, you can make an argument that the median overall survival benefit here is a little bit more remarkable, or a little bit catches your attention a little bit more because it's happening in patients who have already been treated with something else. But nonetheless, it's still the case that, again, these are not really game-changing drugs. I will say that I think regorafenib falls into sort of the same bucket as sorafenib, in the sense that it's a pretty yucky drug. Patients really don't like taking it. It causes a lot of off-target side effects, sort of the same story where you can have both the dangerous acute side effects and also the patients who really just don't feel very well. Cabozantinib is maybe a little bit better tolerated in my experience, but has a pretty similar profile. And then this is, again, so this is looking at lenvatinib, which the trial came a little bit later, but is the other one that is approved in the first line setting. You'll notice if you look at this overall survival data here, I just want to make sure that it's clear. This is a non-inferiority analysis, so they're not comparing this to placebo. They're comparing using lenvatinib versus using sorafenib, and basically showed that these are very comparable, although you can make an argument that there was better progression-free survival, as you can see here on the lenvatinib versus sorafenib, for those who are not looking at oncology drugs all the time. This is a quandary that we face sometimes. It's always a little bit hard to know what to make of a drug that keeps you longer from progressing, but still doesn't keep you alive any longer. For the most part, because these are patients who unfortunately often do not live for very long, we really look at median overall survival as the sort of our go-to endpoint. You can look at other things like progression-free survival, but that's really, I think, where the most important money is. The other thing that I think is important to notice here, when I see a patient with most other malignancies in clinic, be it colon cancer or gastric cancer or whatever, when I give them their upfront chemotherapy, I'm really hoping that they are going to have I don't just want the therapy to arrest the growth of their tumor. What I'd really like is to see their tumors shrink significantly. The original study of sorafenib really showed very little ability at all of the drug to actually shrink the tumors. It would aggress the growth in some, but very rarely shrink them. It seems on this trial and other subsequent trials that there is some ability of sorafenib to do that, and we do see that sometimes, but lenvatinib appears to be able to shrink them significantly more often than sorafenib. Nonetheless, in none of these is it usually a gangbusters response, although every once in a while we do see a really significant one. The other thing to remember here, again, is that in spite of progression-free survival differences or overall response rate differences, we're still left with an overall survival benefit that is on the order of the same magnitude as what we see with sorafenib, which at the end of the day, as I said, is what we really care about the most. This is then just summarizing what I've just talked about. I think for all intents and purposes, it's best to think about these 4 drugs as falling into sort of the same bucket. They're all small molecule inhibitors. They can all have off-target effects. They can all make people feel pretty sick and also have sometimes relatively rarer, but nonetheless dangerous acute side effects. And they all offer median overall survival benefits that are on the sort of the same order of magnitude, usually around 2 to 3 months. You may ask, well, can you only use one of the first line ones and one of the second line ones? That's an interesting question. We don't end up coming up against that too often, mostly because we have other therapies from other classes of drugs now that we tend to use more often. And so the strategy, I think, for reasons that we'll talk about in a minute, would be to use maybe an immunotherapy drug, then a first line small molecule inhibitor, and then a second line small molecule inhibitor after that. In theory, if you still needed other medications to use after that and the patient still had the performance status for it, you could probably think about using one of the other ones that hasn't been used so far. Okay, so then this is another drug that has now been shown to be effective. This is called ramucirumab. Ramucirumab is a VEGF inhibitor that is given as an IV. It's a monoclonal antibody, as you can see there. This was also tried in second-line disease. It's important to note that, interestingly, this was first trialed in patients. They opened the trial to patients who had any degree of AFP, and in that trial, it was shown to not produce a statistically significant overall survival benefit. However, they noticed that there seemed to be more of a signal in patients who had high AFP than in those who had low. So then they went back and did a second trial, generating a hypothesis from the first one that maybe it would be effective in those who have a higher AFP. And in that trial, it did yield a median overall survival benefit that was statistically significant. Again, though, back to the sort of the theme of these kinds of drugs, the median overall survival benefit is statistically significant, but not particularly clinically impressive. And you can see here again, highlighting the theme that I brought up before, the response rate, which is the percent of the time that the tumors significantly shrink based on a CT scan, is still really quite low. Okay, so then we get to the drugs that have really changed the face of treating this disease. So as those of you who have followed the oncology world will be aware, about 10 years ago, for metastatic melanoma, not hepatocellular carcinoma, but for metastatic melanoma, it was a similar situation. It was probably tied with HCC for the least treatable malignancy. We had nothing to offer these patients. And then about 10 years ago, we started to see the results of the initial trials looking at the use of monoclonal antibodies against PD-1 and PD-L1, which are immune checkpoint molecules. And those have first absolutely changed the face of treating melanoma, where 10 years ago we had nothing to treat the disease with. And now it appears on long-term analysis that about a quarter of the patients who had metastatic melanoma and were treated with those monoclonal checkpoint inhibitors appear to have been cured of their metastatic disease, meaning that it has gone away and may never come back. So then, of course, after that, there was a mad rush by every drug company to make one of these monoclonal antibodies and trial it in every disease, including hepatocellular carcinoma. One thing that is interesting about this is that the GI malignancies have arguably been one of the more resistant subtypes in terms of these checkpoint inhibitors. For colon cancer, for instance, they're almost completely useless. For pancreas cancer, for instance, they're almost completely useless. But one of the bright spots among the GI malignancies has been their use in hepatocellular carcinoma. And so Nivolumab is one of these drugs. It's a monoclonal antibody against PD-1. And basically, you can see that in this trial, this also included people who had both hepatitis B and hepatitis C. This included people who were not able to tolerate sorafenib, which, as I mentioned earlier, is a significant percentage, or those who had progressed on sorafenib. And what I would draw your attention to on this slide is that the overall response rate, which is again the percent of patients who have actually had their tumor significantly shrink while on therapy, is higher here than what we typically think of with the small molecule inhibitors that we were talking about previously. The other thing that I think is important to recognize here is that sometimes in oncology, we tend to focus on the overall response rate, which only includes partial or complete responses. But it's important to note that the stable disease rate, which is here on this row, is also important because in the oncology world, if your disease doesn't grow on therapy, we still consider that a win. And so what you can see is that the overall survival for these patients out at 9 months, which is pretty long if you think about the other survival numbers that we've seen for HCC, is significant, ranging between 60 and 80%, depending on their hepatitis status and other things. This is another trial. So this is looking at using a combination of immunotherapy drugs. So now we have a PD-1 or a PD-1 inhibitor as well as a CTLA-4 antagonist. So this is basically just attacking two different parts of the immune mechanism to try to unleash the immune system to attack the cancer even more strongly. What you can see here is that the overall response rate, the percentage of overall responses, is even higher, where we were previously seeing in the range of 20%, now we're seeing in the range of 30%. The thing that I think is important to note, though, about these drugs is that at this point, when you're unleashing the immune system to attack the cancer to this degree, this is significantly more toxic than the single drug nivolumab was. So the patients who were treated with these drugs in combination much more commonly develop sort of low-level autoimmune side effects, but they can also, not particularly commonly, but there is a significant percentage of them who can develop devastating autoimmune effects that can sometimes be fatal. It only takes 1 or 2 times seeing one of these patients who's developed a devastating autoimmune side effect to learn that you need to be very, very careful with these drugs. I think that's also an important thing for all of you to know when you're counseling your patients who are meeting with medical oncologists and talking about going on to immunotherapy drugs. There's a sort of an urban myth that is in circulation that immunotherapy drugs are sort of the free lunch of medical oncology because all they do is unleash the immune system, right? And we have lots of patients who are talking, they always talk about, well, I want to boost my immune system. So then they have this idea that these drugs just boost the immune system and that they therefore don't have any side effects. It is true that if you take a normal cytotoxic chemotherapy drug or a small molecule inhibitor and compare most of the patients on that drug to most of the patients on especially single agent immunotherapy drugs, the people who are on cytotoxic chemo or on small molecule inhibitors are much more likely to have day-to-day side effects than the immunotherapy folks. But the people on immunotherapy can still develop devastating side effects, and it's important to emphasize to patients that this is not a free lunch, even though we do, of course, sometimes recommend it. This is a study looking at nivolumab versus sorafenib, and basically the take home here is that the nivolumab, which is in the blue, has a better, you can see the separation of the median overall survival curves, especially towards the latter part of the curve here. This represents an important trend in immunotherapy drugs, which is that of the patients who respond, many of them respond for a long time. So you'll have some patients who get onto nivolumab and then they may have a response, as is indicated in this graph, that lasts for years. And then the last specific therapy that I want to talk about is, so now, the big question in oncology, we've trialed these first generation immunotherapy drugs in most of the different cancer types. And so now one of the burning questions is, can we combine that therapy with some other kind of therapy? This is a trial that looked at using atezolizumab, which is one of the immunotherapy checkpoint inhibitors that we've been talking about, with bevacizumab. Bevacizumab is a monoclonal antibody against VEGF, so it's trying to prevent tumors from making new blood vessels. And what you can see here is that this combination was trialed against sorafenib. And so if you go back and you remember this curve here, where you really see very little separation of the curves until about 18 to 24 months, this is looking at just at 12 months. Now, I will point out that the median overall survival arm, even of the sorafenib, looks pretty good here, maybe a little better than in some other trials. But you can see that this is a pretty distinct distance between the curves that really starts after just a month or two. And I think that of all of the new treatments that we have available for hepatocellular carcinoma, arguably this is the most exciting new advance, is this combination of therapy, both because of this specific combination and also because what we hope it portends for future combinations using immunotherapy together with other drugs. Now, I should mention, just to be clear, that because this bevacizumab is a drug that works by blocking the formation of new blood vessels, one of the side effects, as you might imagine, is significant bleeding. And so back to the point that I made at the beginning about the fact that these very patients who need these drugs are often the ones who are most at risk for the side effects that they can produce. It's pretty routine part of our practice that if we have a patient who we're thinking about putting on atezolizumab and bevacizumab, we want them to get an EGD first to make sure that they don't have significant esophageal varices. Because if they do have esophageal varices or other things that would put them at higher risk of bleeding, given that bevacizumab has that as one of its known off-target effects, that makes us much more wary about using it in that context. So if we then try to sum all of this together, what you can see is that now, as I mentioned before, I think that most of the time what we are doing now is, unless there's a contraindication, we tend to use nivolumab, which is the immunotherapy drug, alone up front, or now, because of the slide that I just showed, atezolizumab plus bevacizumab. Oh, the one other thing that I should also mention, nivolumab alone is nice because of all of the drugs listed here, it's arguably the one that is the most forgiving in terms of its side effects. So if you have a patient who's a little older, a little bit worse performance status, maybe has other, greater possibility of side effects, has a little bit of worse liver function, any of those things, nivolumab is probably the one that is the safest to go to in that kind of a setting, certainly more than the small molecule inhibitors or even than the atezolizumab and bevacizumab. And then in the second line, we have all of these available as well. As you can imagine, part of the challenge here, ironically, is that whereas 5 years ago we had virtually nothing with which to treat this disease, now we have this whole bevy of medications, and a lot of the questions that remain now are about how to mix and match or what sequence to use these in. So in summary, this really is a new era. You can make an argument. I think it is true that more drugs have been approved for the treatment of HCC than for any other solid tumor malignancy in the last 5 years. Whereas 5 years ago, I felt essentially useless when we got a patient with HCC. Now oncologists really do have a major role to play here. Targeted immunotherapies are playing probably the biggest role, and combinations offer even greater possibilities down the road. So with that, I, again, thank you very much for your time. And Dr. Hold, I don't know, do you want me to take live questions, or are you reading from the chat, or how do you want
I think the only live questions right now are mine, but I have a couple. So Dr. Johnson, first, thank you so much. That was, I could tell it was going to be a good talk because you had a smaller number of slides, and I knew you were going to really tell us about what they said. And I filled in a lot of gaps in my own knowledge there, so I appreciate it. So my question is a statement and then a question. So I've been in practice about 5 or 6 years as well, and I came in right as these things we were getting excited about anything other than sorafenib, and we would really never ever refer anyone to oncology unless they had stage 4 disease.
Yeah.
Still, mostly that's the case in transplant, but just in the last 6 to 12 months, maybe not even, maybe 3 to 6 months since we've had atezolizumab, bevacizumab, and some of this exciting data, I personally have referred 1 or 2 patients who were not transplant candidates who had, say, a T3 lesion, but maybe it was infiltrative, or something about the lesion that I might have previously sent for local regional therapy. My question is, are you also noticing a change in your referral patterns based on what you just presented? And do you think that you'll continue to see a change in the future? I wonder how far we're going to go.
Yeah, so I think it's a great point, and I think what it really emphasizes more than anything is that more than ever before, hepatocellular carcinoma is it always has been a multidisciplinary disease, but I think that we really need to sort of extend the reach of that initial multidisciplinary conversation to include the medical oncologist. 5 years ago, as I said, occasionally I would get referred patients where it was kind of like, well, we're hoping to, maybe get to transplant at some point in the future, or we're hoping to get to surgery or something. And I would kind of say, well, I'd love to help, but I don't really have much to offer here, right? But now those conversations really are a lot more nuanced, because we do have, when we have our liver tumor board that meets here, we do have more conversations that involve, a question of, well, can we do systemic therapy to try to get this response that we need in this place, but maybe we use liver-directed therapy over here for this specific lesion, or whatever. As I mentioned before, the response rates for sorafenib are low enough that it would pretty much be a fool's errand to think that you were going to use that for any, meaningful role here. But with the new therapies, and as you mentioned, especially with the atezolizumab and bevacizumab, I think that that has become a much more live question. Again, I want to emphasize that there is no free lunch here, right? So all of the therapies that we're offering have potential side effects, and sometimes those side effects can be serious, but it's definitely a conversation that is happening in a much more meaningful way now.
And I'll ask one more question. This is a pushing the limit question, not with child score, which we always ask you to do, but with autoimmune disease. So it's come up several times when we have HCC recurrence after liver transplantation. Are these patients going to be eligible for these immune checkpoint inhibitors? And in my practice so far, I have not. And I have not worked with someone who has given a checkpoint inhibitor to a patient on immunosuppression. I also have a patient with pretty severe RA, and we also were pretty nervous about giving her a checkpoint therapy. I wonder if you've come up against some of those, and if you've made similar decisions, or if you've had experiences where patients have been able to tolerate it in those settings.
Yeah, so that's a good question. And it's important to separate those into separate questions, because they're not the same thing. If I look at patients so let's go to the second part first. If I look at patients who have some sort of significant autoimmune disease, when the immunotherapy drugs first came out, for obvious reasons, so I should say first, giving an immunotherapy can recapitulate virtually any autoimmune disease that you can think of, right? And so because that's the case, there was a very understandable concern that if we gave immunotherapy to patients who had pre-existing autoimmune diseases, that would exacerbate them. That is certainly possible, but you should be careful not to write off patients from the possibility of getting immunotherapy because of pre-existing autoimmune diseases. When I get referred a patient who has, for instance, inflammatory bowel disease, who has, let's say, colon cancer, and maybe has a mutation that makes them susceptible to immunotherapy, their tumor susceptible to immunotherapy, I'll have a discussion with the gastroenterologist where we talk about how severe has it been, what kind of comorbidities they have from it, how much medication have they needed, et cetera. And then we'll have a discussion with the patient. But if immunotherapy is clearly the best therapy to offer, and if they have an autoimmune disease that has been at least reasonably well controlled with immunosuppressive therapies or whatever, in that setting, we often will try immunotherapy, especially if it gets to a point where they don't really have any other good options except for the immunotherapy. We'll often try it. The good news about most of these side effects is that most of them are steroid responsive, and most of the time you can salvage the patient from the side effect even if they have it. Not always, and obviously there's a spectrum, but I would certainly not cut someone off from immunotherapy before even asking for that reason. Transplant is a little bit of a different deal. So there is a pretty good case series, I think out of MD Anderson, looking at using immunotherapy in patients who are status post solid organ transplant. The majority in that series are patients who had renal transplants. And basically what it shows is that it's risky business. There is a significant percentage of them who have graft failure, and a significant percentage of those who go on to lose the organ because the graft fails permanently. There are some who are able to get away with it. We don't know how to differentiate them yet, but it is a significant toxicity. In terms of doing it to patients who have had liver transplant, I've tried to ask around about this a little bit. And, I have found sort of an urban legend here or there about somebody who was, clearly dying from their metastatic HCC, who was status post liver transplant. And then because they were dying anyway, we threw immunotherapy at them, and then they died from liver failure. But who knows if that was from, the immunotherapy or because they were dying from liver failure already. But I have not been able to find any data that I find reassuring enough, certainly to suggest that that's okay in any general way. I mean, if you're really up against the wall, you could always discuss it with a medical oncologist, but certainly not something that we do routinely.
Well, thanks very much. That's really great to hear. So Dr. Johnson, thank you very much. I appreciate your time and your talk and your expertise. I am now going to turn it over to Dr.